Mr. Griffin.
Can we move on now, Mr. Trent, to discuss some of the concerns that have been raised about the operation of Oxyvision? One of those concerns relates to its operation in the way it creates multiple alerts, and we've spoken about that already, which it may be hard for staff to monitor and could lead to alarm fatigue. Is that a risk or a concern that you're aware of?
I'm aware of that concern.
You say in your first statement, and this is paragraph 29, that in May 2021, EPUT's OxyHealth Project Board explored the potential to lock down the audible alert volume to 75% on the fixed monitors. This was explored to remove the potential for staff to be able to physically change the volume setting. The outcome was that there wasn't a practical method to eliminate the possibility on the fixed monitors. However, all tablets are preset at 75% volume and are not adjustable by staff. Now, that was before you joined EPUT, but is it in fact the case that the catalyst for making this inquiry with OxyHealth was the death of a 16-year-old patient, Elise Sebastian, the previous month?
Yes, that is correct.
Elise's death was on the 19th of April 2021. Oxyvision had been introduced in the ward 2 months beforehand. Did Elise's death reveal that staff were muting or reducing the volume of Oxyvision alerts on wards?
Yes, it did.
Was this considered a clear risk to patient safety?
Yes, it was.
Why would staff mute or reduce the volume of Oxyvision alerts?
I do not know why staff in that case behaved in that way.
Could it be the result of alarm fatigue?
That's one possible analysis.
Laura Cousins referred in her evidence to a number of inquests, this was yesterday, following deaths at EPUT where Oxyvision had been used. 3 of those inquests involved the muting or resetting of alarms by staff. Now, we've just spoken about the situation where with Elise Sebastian on the 19th of April 2021. But there was also Michael Nolan, who died on the 10th of July 2022. And that would have been shortly after you joined, I think, EPUT, correct? And then the death of Morgan Rose Hart, who died 2 days later on the 12th of July 2022. Now, as we heard yesterday, those deaths are 15 months apart. You'd accept, would you, that clearly there was an ongoing problem at EPUT with staff muting Oxyvision alarms?
I think it's important to distinguish 2 different issues here that both relate to alerts and alarms. The first issue, which I address in that first bullet point of paragraph 29, was that the monitor had been turned, the volume had been turned down. And what that means, in effect, is that when an alarm was raised in the system, nobody heard it because the volume was off. That's different from an alarm being raised, a member of staff seeing and hearing that alarm and inappropriately resetting it without following the standard procedure to attend in person. And I think in these cases, there's a difference between the way in which staff behaved and what the coroners have found.
So I think what you're saying is that there are different categories of problem here. They both relate to system alerts.
Yes, one of those was essentially a problem, in turning down the system so that people couldn't hear any alarm at all, and the other was in how staff responded to alerts, which they responded in a way that was not in line with the policy.
2 issues relating to Oxyvision alerts, correct?
Yes.
and they don't appear to have been properly addressed, at least for a period of years or at least very many months, correct?
Well, as I say, they're different issues, and I think you highlighted to me earlier that the earlier version of the SOP had the point in it which staff should attend to patients when there is alarm before resetting it, and that point of policy was already in place. Staff did not follow that, with tragic consequences.
You say in your second witness statement, paragraph 8, there should have been greater oversight at the outset of the practical use of Oxyvision on the wards, in particular to address alarm fatigue and to ensure that each alarm was always actioned by a face-to-face visit with the patient and that alarm volume settings were not adjusted by staff. Would you agree that it was entirely foreseeable that staff might seek to mute Oxyvision alerts?
It's difficult for me to say whether that was foreseeable or not. What I'm saying in the second statement is, the trust accepts that it should have done better in relation to these matters in terms of the oversight and management of staff, and making sure that staff were fully complying with the policies and procedures that were there.
So my question was, would you agree that it was entirely foreseeable that staff might seek to mute Oxyvision alerts? Is your answer to that you can't really answer?
Well, my answer is that the policy was clear, and we expect staff to follow policies and procedures, that they should attend alerts and not reset them without attending. However, as you say, there was a risk that they didn't do that, and I accept that was a risk. And as I say, the trust accepts that it should have done more to manage those risks historically.
Who was responsible for providing the necessary oversight for matters such as this at EPUT?
So we touched on this very briefly earlier. The oversight of staff on the wards sits with the nurse in charge, the ward manager, the matron, and we have an accountability framework system and a senior leadership team accountable for a care group such as inpatient services that then reports into committees and the board. So there's a system of accountability there. The compliance and adherence to policies and procedures on a day-to-day basis is something that the nurse in charge and ward manager and so on should be overseeing.
Was it not recognised by EPUT leaders that a newly introduced technology required robust oversight to ensure that it was functioning properly and safely from the start?
So the Trust had in place a project board from the outset of this programme of implementation, chaired by the Chief Operating Officer with clinical and operational leaders. So there was a trust-wide oversight of the implementation, and there's also ward-specific and care group-specific oversight as well. So those mechanisms were there, but they clearly did not prevent these tragic events.
Isn't that a theme, that there are policies and expectations in relation to policies, but it doesn't necessarily follow that if something's in a policy, members of staff will follow it, correct?
This is an issue that Paul Scott addressed in his position statement, that matters of compliance with policies has been an issue at the Trust and continues to remain an area of focus as we go forward.
And that there may be systems in place and people with designated responsibilities, but the fact that they exist doesn't mean that they are actually working to reduce risk or to address risk.
I think colleagues at the Trust are, for the most part, working hard and doing their best to address those things. But it's evident, and we acknowledge in this statement that that has not been done to the highest standard that it should have been in the past.
May I ask you some questions about tablets, please? And we saw a
Yes.
photograph of a tablet. How many members of staff on a ward should be carrying Oxyvision tablets?
So I think that varies ward to ward, and wards can request additional tablets. I couldn't give you a specific number.
So Laura Cousins suggested that typically there'd be 2 or 3 a ward, but possibly more where Oxyvision observations was being used. Does that sound like an average, or is it impossible to say?
No, I mean, it would normally be more than that, because you'll have multiple staff members doing observations at a given time. So, I would say from my visits, I've seen, 4 to 6 would not be unusual. But we could give you a more definitive answer on the number of tablets, if that's useful to you, Chair.
How is it decided who should carry a tablet? Is one given to every member of staff, for example?
So, the nurse in charge in a ward will assign observations to different members of staff, that the practice of conducting engagement and observation with patients, and will be clear about which members of staff are supporting which patients, and will ensure that those members of staff have the tablet that they need to do that. And the key thing here is that Oxyvision is not a standalone system. It's a tool that the staff are using to carry out that. So the normal oversight of who's doing observations is we'll take that into account and ensure they've got the right tools.
So it's not on the basis of a particular category of staff. It could be anyone, for example, a healthcare assistant, or it could be someone much more senior.
Yeah, often it will be a healthcare assistant, but nurses will also undertake observations. We have a multidisciplinary team on the wards, so it's not limited to one single profession, no.
Are there backup tablets on ward if one isn't working?
Yes, there's usually enough that you've got a couple spare that could be used if there was a problem.
Is malfunction an issue with either the hardware or the software?
Not that's extensively reported. I think, one of the issues earlier on in the use or the deployment of the tablets as an observation tool was making sure that the trust had good enough Wi-Fi everywhere that the tablets could upload to that. The software does have an ability to hold data until they get back into Wi-Fi, though. So it wouldn't, a staff member can still conduct their observation even if they're outside of Wi-Fi. And I'm pleased to say that our Wi-Fi has improved significantly at the trust. So that's not a widely reported issue now.
But it wasn't it, in Elise Sebastian's case, where handheld monitoring tablets were not working because of poor Wi-Fi?
That's correct. I think there was an issue with the software, I believe, as well in that case.
Stop Oxyvision raises the possibility that non-medical staff, other patients or visitors could also view patients in their bedrooms from the Oxyvision tablets, or possibly even the monitor. Would you accept that this remains a risk in respect of the current use and operation of Oxyvision?
So, when in the nurse's station with the monitor, and I think this was shown on screen yesterday, you have the tiles that don't show images. That risk is minimised by those images not being available unless gone into. Clearly, at any point that somebody goes through the workflow, just as at any point you're doing anything, somebody can look over your shoulder. That's always an information risk. Staff are aware of the importance of protecting privacy and dignity for patients, and just as they would be cautious in knocking on a door where before entering in normal circumstances, making sure that other patients are not following them into the room. They should be carrying out the same good practice in relation to use of the tablet.
So that's the expectation. Do you know whether in practice there is an issue with inappropriate use, for example, of the clear view function to access clear views of people in intimate moments in their bedrooms?
I I know that there's a concern about that, and it's why we changed the standard operating procedure and made that point, the point I made earlier about making it explicit about the use of how that should be used. It remains a risk.
What about access to the information on a tablet? Would it be possible to access the vital signs function, for example, the work stream, without having to log in or to go through any security function?
I understand you have to log into the tablet to be able to do that. And I also understand, and we've had conversations with Oxy Health about this, that they're bringing in a new authentication capability, which will improve that, provide a better control in the technology in the future.
Does the standard operating procedure say anything about those with tablets, staff members with tablets, using them in a discreet way, not in open areas?
Chair, I'd have to recheck that to be sure. The engagement and observation policy, which is cross-referred to in the standard operating procedure for Oxy Health, is clear about privacy and dignity, and those themes, I think, are borne across. Whether it specifically says in relation to the tablets, I'm not sure. I'd have to check that.
So we're just checking that, Chair. My recollection is that it doesn't.
Because it does pose a risk, doesn't it? I mean, you talked about looking at the monitors in the nurses' station. That's a closed environment, but the nurses themselves are holding these monitors in the tablets in their hands, because it's while they're out and about engaging with people. That's the idea. Clearly that is going to raise a risk that somebody can see what's on their tablet.
Yes, I agree. It is a risk, and those engagements and observations, however, are more likely to take place in somebody's room if you're using the Oxyvision system, because the system is only for the private bedroom. Being near to the room and such like.
Can I just ask you to clarify a part of your evidence a moment ago? You said you thought people would need to log in to use a tablet. But if a tablet was left somewhere, would it be possible for a patient or someone visiting the ward to pick it up and access, for example, the Clearview function?
I think the tablets lock after a period of inactivity. I couldn't immediately tell you how long that period is, but we could confirm that.
Thank you.
Again, staff are clear that they must not put down the tablets except in the nurse's office.
Is there any policy that actually says that?
So there's training for staff with the Oxy Health Academy, and there's 2 courses there. There's an OLM training course, and then there's also a staff competency checklist, which is where a more senior member of staff on the ward will assess an individual as to whether they understand how the system should be used, and how to ensure that it's used appropriately and to minimise the risks around it.
I'm not sure that's answered my question, though. Is there any policy that expressly says that staff shouldn't put down tablets and leave them unattended?
I would have to re-review those documents to be sure.
Thank you.
But I think with any policy or procedure, we try and make explicit as many aspects of risks as possible. But there is an important point about reading those policies and procedures in their principles, and they will set out principles often of how staff should behave and conduct themselves. And I think these particular examples would be inconsistent with the overall principles and objectives of the policy, whether or not they're called out as specific points. But certainly if they're not, those are areas that we can improve our policies, and we would seek to undertake that.
I'd like to ask you next about a concern that the presence of a camera in a patient's room may exacerbate underlying conditions. As we've seen, the camera unit in the bedroom is large and would be obvious to the patient. Do you agree?
Yes.
The inquiry will be hearing evidence in this session from Tammy Smith, and as we heard yesterday, her daughter Sophie Alderman tragically died on the 19th of August 2022 while in EPUT patient, and the inquiry will hear that the presence of what is presumed to have been an Oxyvision camera in her room may have caused or exacerbated severe paranoia. Should it not have been anticipated from the start that for certain patients, the presence of a camera in their rooms might be troubling and could exacerbate underlying conditions?
Yes, this should have been anticipated sooner, and it's one of the things that I've said in my second statement. I've heard Tammy Smith's impact statement to the inquiry and take extremely seriously the concerns there. I've said in my statements, we've raised with OxyHealth whether the equipment can be adjusted or a shutter or some other mechanism put in place to reduce that risk. And I know, as we've heard yesterday, they're redesigning it, but we don't have a firm timeline yet on when that would be released.
Is that in their hands? Because I think the evidence was it wouldn't be until next year at some time.
We don't, we're not able to ourselves make an adjustment to those devices. If we did so, it could compromise their capability in other ways. As an organisation, strategically, and in our policies, and you'll see this in the annex to the engagement and observation policy, we've committed to becoming more trauma informed, and this is an area we've got more work to do. Responsible clinicians, however, will have a responsibility, and the multidisciplinary team, to ensure each patient is treated according to their own needs, presentation, etc., and has a care plan appropriate to them. While we don't currently have the facility to physically remove or block the camera, those considerations should be taken into account. Any potential traumatic impact should be taken into account by the care team in planning the care for that individual.
Thank you. We heard yesterday, and we've touched on this today, that the illuminators, I think you call them, the infrared aspect of the camera is glowing red all the time. Isn't that a problem for patients for whom the presence of a camera is already troubling?
Yes, I agree, and I've acknowledged that in my third statement. This is why it's so important that we get right, and acknowledge again that we haven't always gotten this right. The engagement with patients at the point of admission, and the material and information that's given, not just in paper but verbally and through ongoing discussions. Those are the mechanisms that are so important for patients to understand the system and how it's used.
Another concern that's been raised is that in practice, the availability and use of the Oxyvision system at EPUT has undermined therapeutic engagement between staff and patients rather than supported it. And I'd like to ask you about that now, please. You've referred to Oxyvision as an assistive tool for staff, and you've said that observations other than for taking vital signs should be in person. Yes?
Yes.
In your statement, you add that EPUT ward staffing levels are determined by the Trust's safer staffing model, not the use of Oxyvision. There is not a separate staffing model for the use of the technology on inpatient wards, and you add Oxyvision is operated by ward staff as part of their normal duties. Therefore, the use of the technology does not affect the level of ward staffing in practice. That's paragraph 55 of your first statement. Do you think that's right, in fact? Do you think that what you say there might actually represent the theory rather than the practice?
No, I do think that's right. As Paul Scott said in his position statement, over this period, EPUT has increased its substantive staffing since the point at which we started implementing OxyHealth. And the Time to Care programme has added over 300 multi-professional staff to our our wards. We've been and that time to care programme really does also focus in on practice and ties back to the guidance around fundamentals of care and so on. So over this same period that we've introduced and rolled out Oxyvision, we've also invested in staffing on our wards, and we've also changed, we've improved that multidisciplinary mix with peer support workers, that's people with lived experience on our inpatient wards, and activity coordinators as 2 new roles, for example.
But over the period we're talking about, it has been an issue, hasn't it?
Sorry, would you repeat that question? What's been an issue?
The issue of understaffing potentially, and the issue of EPUT staff relying too heavily on remote observations rather than in-person observations.
There certainly has been, and we've heard about that in terms of the evidence from inquests and elsewhere. Staff have over-relied on Oxyvision at times. That's absolutely correct. We have significantly, as I said, increased our nursing establishment and ran a successful international recruitment programme as well, in the ways I've just described over that period. However, as with all mental health trusts, there are days when staffing is pressured, where on a particular ward or a particular unit, for whatever reason, we find ourselves pressured on staffing, and there are escalation processes and procedures to do that, including getting additional bank staff or, if necessary, agency staff to support on the wards.
Do you agree that observations by staff in person are an opportunity for establishing a therapeutic relationship with a patient?
Absolutely and wholeheartedly.
And does it follow, if those observations are conducted through a screen via Oxyvision, that opportunity for therapeutic contact will be lost?
Yes, I agree.
Has Oxyvision, in fact, made work for staff? You talked about how the alert system requires somebody to go and respond to those alerts, and we saw the numbers of alerts that there have been. Would you think that has actually added to the burden of staff work?
It's a question I ask staff when I go and visit, actually. I say to them, is this better than when you're doing it on paper? And they generally say yes. They like the fact that it's easy to use. They like the fact that it prompts them on observations being timely. The more senior staff members like the ability to oversee that more rigorously. And staff have, on multiple occasions, told me that it's assisted them in saving lives and responding to incidents more quickly. And that matters tremendously to our staff, that they're able to respond quickly when a person is in crisis, to support them in the best way they're able. So, generally the views I've heard from staff when I've talked to them about Oxyvision is that it has been useful and assistive.
The failure properly to train staff that Oxyvision was not an alternative to face-to-face observations and engagements has been a feature of inquests in relation to patients who died in EPUT mental health units. I think you've just averted to that.
Yeah, I accept that.
For example, Michael Nolan, who, as we've heard, died on the 10th of July in 2022. The narrative conclusion at his inquest included that the Oxyvision training was inadequate because the clear and concise message that it was not an alternative to face-to-face observations and engagements was not effectively conveyed to staff. And in Morgan Rose Hart's case, who, as we've also just heard, died days after Michael Nolan, the report to prevent future deaths following her inquest refers to observations mainly being completed via the Oxyvision system, and that there was limited therapeutic engagements or attempts to engage with Morgan Rose. Do you agree that those inquests raised matters of grave concern about the operation of Oxyvision?
Yes, I do. And it's why we've made significant changes to the training process, and now consider that to be much more robust than it was at those times. I referred to it earlier. There's 3 key elements of the training process that's now in place that was not at that time, which is the use of the Oxy Academy material, which is provided by Oxy Health. So they are experts in their own system and how it operates. Our own OLM training, which is an online training that's developed by the Trust and particularly pulls out elements of the standard operating procedure, and then the staff-led assessment against the competency checklist to make sure that staff understand a number of different points about how the system should be used in practice.
So these are recent changes to training, are they?
Those changes to training have been introduced over the last year to 18 months, I would say. I mean, certainly, after those sad deaths, EPUT has undertaken improvements between that time and now. I'd need to go back to colleagues to be more precise on exactly when specific training materials were updated.
How much of that training is online?
So the first 2 elements, the Oxy Academy is online, as I say, provided by Oxy Health, and the OLM is online. The third bit, the competency checklist, that's done by a senior member of the staff in person through discussion with a member of staff.
Given the significance of training in this area and in other areas, do you think having such a substantial proportion of it online is appropriate?
I mean, in preparing to give evidence, I've completed all 3 of those pieces of training myself, even though I'm not a clinical member of staff. And I found the online material to be informative and to cover the key features of the system in a way that was accessible. The third element is the in-person piece and the competency checklist, however, which gives assurance then that in practice somebody knows how to use the system, and that can be supervised by somebody who has more experience of using it.
Thank you. You explain in your first statement that EPUT has also been using a system called I Want Great Care to collect and process feedback since the start of 2022. You provide details of the feedback located in relation to Oxyvision between July 2023 and July 2024. And could we just look at an aspect of that, please?
Certainly.
Would you put up EPUT 009020, please, and show the full document? So this is the feedback that EPUT has located. Would you expand the top 2 rows? Is it possible to do that? No. So let's just look at the top 2 rows. For example, the second row, we can see a date there. I think that's the 22nd of November 2023. And we can see that this relates to the Chelmer ward at the Princess Alexandra Hospital. And here we see some feedback. So from 2023 towards the end of 2023, I feel that staff looking at Oxy Health all day is not nursing how it used to be. It's less personal. We are always being told we are short-staffed. And then the next free text box says, we need more staff during the day. So that would appear to be a comment from a member of staff. Would you agree?
No, I would think that was a comment from a patient. I Want Great Care is a patient feedback system.
So the patient is saying that from their perspective, that staff are looking at Oxy Health all day, it's less personal, and the patient is raising at the end of 2023 the issue of short staffing. Is that your assessment of that comment?
Yes.
And we need more staff during the day. And do you have any observation about this comment about over-reliance on Oxyvision and short staffing coming as it does at the end of 2023 or towards the end of 2023?
So, feedback around needing more staff during the day, that's something that's fed into the Time to Care programme. It's why we've now got the activity coordinators on the wards and the peer support workers, and the Time to Care programme also invested in other professional staff as well. So I would say that the concern here, clearly that's that person's experience and is of concern to me as well.
Thank you. Would you take that down, please? Now, in terms of concerns about Oxyvision that have been raised, I would like to move on to ask you about an aspect of the video function of the system and where video data is held. We've already heard that it's possible after an incident for OxyHealth remotely to extract clear video data from the Oxyvision server, but that it must be requested by a member of staff within 24 hours of an incident. Otherwise, as we've heard, the data is automatically overwritten. Is that all correct?
Yes.
This is covered in EPUT's most recent standard operating procedure for the use of Oxyvision. And can we just look at that part of it, please?
Yes.
Could you put up EPUT 009884 at page 12, please? Thank you very much. So this is paragraph 1.5.6, and it says this: clear video data is non-pixelated video footage that can be clipped and saved upon request if there's a situation that needs to be further investigated. The ward manager, nurse in charge, or their nominated deputies, site manager, and if out of hours, the on-call manager, can request the clipping of the clear video data. The request must be made directly to OxyHealth within 24 hours. Upon receipt of a request, OxyHealth will clip and save clear video data. OxyHealth will then seek authorization from the named CVD approvers. Once authorization has been granted, OxyHealth attends site to transfer the clipped CVD to a secure USB for delivery to the lodge. And it says at the bottom, clear video data is automatically deleted from the local Oxyvision server on EPUT sites after 24 hours. And so it's reiterating that important point. We learned yesterday from Laura Cousins that in fact, when Oxyvision is activated in a person's bedroom, the camera is always on and always recording. Is that also your understanding?
So may I say something about what you put on the screen?
Yes, by all means.
I believe that's from an older version of the standard operating procedure in terms of the USB, because that's not the current practice.
In fact, it's from, we'll just double check, but it's from the current version. So the current version may be out of date.
I think we've addressed this in the data protection impact assessment and the data flows. So on the point about where the data is held, there's a server on site at EPUT, and the process is there must be a phone call to the OxyHealth 24-hour line to request it's clipped. Then staff within EPUT can't conduct that themselves. The OxyHealth team will do the clipping, and then there's a secure transfer, which Laura Cousins spoke about yesterday via the egress system.
Okay, can we take this in stages?
Yes, of course.
This is from the current, most recent version of EPUT standard operating procedure. So the first point is this: it's incorrect, isn't it?
Please let me just read it for a moment. Yeah, so the bit that is incorrect, which describes past practice rather than current practice, is the following. That OxyHealth attends site to transfer the clipped CVD to a secure USB for delivery to the lodge, and so on. That process of transferring data via a secure USB was the practice previously. That's now been replaced by the egress system that Laura Cousins spoke about. The rest of the process is correct about how a staff member would request something is clipped.
why is it necessary for OxyHealth to be involved at all in the retrieval of clear video data?
Because they have the ability to do that and extract that for us. Our staff are not able to do that directly themselves. It's part of the process that's been in place since we first started using Oxyvision, and it effectively acts as an additional control, because it means that that's highly sensitive data, clearly. And you have to go through a document, this process in order to be able to access that.
Do OxyHealth ever hold clear video data themselves, for example, on an OxyHealth server, cloud solution, etc.?
No, not to my knowledge.
Is that something you can check and come back to us about?
Well, I've reviewed their data protection impact assessment and our own, and that's not my understanding. I will ask our data protection officer to further confirm that, but no, I don't think that they do have that.
Do OxyHealth ever have access to unencrypted clear video data from ePut?
No, the process is they transfer that to us, and I think the data protection impact assessment and latest data control guidance that's exhibited to Laura Cousins' statement sets out some of the detail about that, and about how they ensure that their staff do not have access to that.
Are there any other circumstances, other than to assist ePut following an incident, in which ePut clear video data might be accessed and held by OxyHealth, for example, for research purposes or to develop its products?
No. If there were, so if for example, a member of staff made a request for the footage to be clipped, and it was outside of that core purpose of a patient safety review of an incident, then the data protection officer would escalate that to the Caldecott Guardian and the CSIRO to consider on an exceptional case-by-case basis. So, for example, perhaps there was an incident that was not patient safety but may have been concerning for another reason. Those kind of things would be escalated to myself and the Executive Medical Director, who is the Caldecott Guardian.
Thank you. Just going back to the question I was asking you a moment back, and that is what you are able to access when you're asking for OxyHealth's assistance following an incident. Mm-hmm. What is available to ePut? How much data and what kind of data is available to ePut, video data?
Up to 24 hours of clear video data at the time that request is made.
And so, as I was saying, as we heard from Laura Cousins yesterday, do you accept this, that when Oxyvision is activated in a person's bedroom, the camera is always on and always recording?
I do accept that footage is continually recorded and is available. I think there's something that's really important in this, and it goes to the discussion about CCTV and how you consider this, which is that the purpose of how this system is used and the circumstances in which someone is able to access that footage is very controlled and limited. So no member of staff is able to view on a CCTV monitor that footage in a live state. That's not, and notwithstanding your points and questions earlier about the vital signs check, we do not have a CCTV TV anywhere that watches the 24-hour streaming. There are only very limited circumstances in which these requests should be made. When they are made, they're reviewed by the data protection officer and would be rejected if they're inappropriate. So, when we're talking about how many times in a year, this kind of footage is viewed, this is tens of times in a year, not hundreds.
But fundamentally, it is a surveillance system, however limited it might be called upon.
I mean,
Do you accept that?
no. I mean, you know, it's a registered medical device that the system uses video camera as part of that device. There are limited circumstances in which you can access the footage. I mean, by analogy, a mobile phone is capable of recording video, but we wouldn't consider that a surveillance device per se. It really matters what the purpose and the procedure for using the device is. So yeah, we absolutely do not, in the Trust, use Oxyvision as a surveillance device. It's, you know, the purpose that's set out in the standard operating procedure is not that. It's to assist in patient care.
But the camera in the room is always on and always recording. Whether or not access to the footage is controlled, that's a pretty significant fact, isn't it?
That is a fact, and that is also on the Trust privacy notice and has been since September 2020. Sorry, 2020 or 2021? I'd have to check that. Since the early stages of implementation, I'll confirm the date. But the Trust privacy notice has been clear about that.
What do you know what it actually says?
Yes, it says to the effect of you know, video data is retained for a period of 24 hours. And I can provide you with a statement that privacy notice has been, you know, it's only one part of the privacy notice. There's a much longer privacy notice. But that's been in place substantially throughout the implementation of this technology. It's been updated twice over that period, once in 2022, where the language was made more transparent than the first one, which referred to salient video, and then it becomes clearer, because obviously I accept that language is not as accessible. And then it was again updated in November 2024 after your moratorium, Chair, to be clear that video would be held indefinitely while the moratorium was there.
The inquiry would be very interested in how express the privacy notice is in explaining that a camera is on and recording 24 hours a day. We'll come on to look at examples of what has been explained in a moment. But I have to say, as far as I'm aware, in the documents that I've seen, it is never expressly explained that what is available is up to 24 hours of clear video feed. So what is explained is this, that there is a 24-hour rolling buffer, but not what is accessible during that 24-hour period.
So paragraph 24 of my statement.
Which one?
I'm sorry, let me make sure I've got the right. Paragraph 24 of my second witness statement, the penultimate bullet point provides a hyperlink to the Trust privacy notice where that's set out. And I would say, having reread that last night, I can't quote verbatim, it is clear that clear video is retained for 24 hours.
But not whether it's literally up to 24 hours of clear video.
And it says words to the effect of, you know, this may be used in serious incidents and to support learning and so on.
I think there's some similar wording that we'll come on to have a look at in another document. So perhaps we can have this conversation actually looking at possibly equivalent language.
Certainly.
But the SOP, as far as I'm aware, doesn't explain that there is a camera that is recording 24/7 and that it's literally 24 hours of clear video feed that is accessible, does it?
Not in those terms.
I don't believe it's covered in your witness statements, other than possibly and we'll verify this through a link to a privacy statement.
I mean, I think I have addressed the point about, video being available for up to 24 hours. And I think, that's it, clearly implicit in that is that it's recording in order to be able to provide that video. But I accept my statements could have been clearer on that.
Well, I think all of the statements perhaps could have been clearer, because what people are aware of is the fact that prior to a vital signs check, a member of staff will have access to up to 15 seconds of clear video feed of the patient, so that they can see whether it's appropriate to go on to make the vital signs check, correct? So the information that we have as members of the public and others is that those are the circumstances in which clear video is being accessed by staff. And so wouldn't most people assume that if there is video data that's available after the event, it would be limited to that, for example?
Limited to what specifically?
Just to the occasions where staff have actually accessed 15 seconds of clear video feed in advance of taking vital signs.
No, and I mean, there's good reason for that. If there were, a serious incident, it may not have coincided with the point at which a staff member clicked to take an observation and see 15 seconds. The point is that in having that continuous video accessible in very, very limited circumstances, it supports a much fuller analysis and learning from what happened. So, appropriate clinical staff are able to review that and ascertain, for example, were there, if there were an incident involving physical health, were there clear signs that physical health conditions were overlooked by staff prior to that? I mean, certainly these are examples where by being able to view that footage in very limited circumstances, I say, we've been able to identify where staff didn't carry out the correct physical health procedures that's enabled learning in the investigation. So you wouldn't have been able to do that if you were limited just to 15-second snippets.
But Mr. Griffin's point was that the statements about what is being recorded and offering people an opportunity to understand suggest that it is only the 15-second clear images that might be being recorded and saved. It's not that there isn't a distinction between, and we understand why they're different things. Do you accept that the impression given is that it is only the 15 seconds that might be being saved?
No, I wouldn't accept that fully. The posters, and I recognise there can be made improvements to these, but the posters do refer you to the website and the ability to contact the DPO and the website and the privacy notice. So there are ways in which those points have been made known.
Should we look at the poster?
I can accept that criticism to say that should have been made clearer and put in more places. But that has been, as I say, has been on the privacy notice for some time.
Can we look at the poster, just by way of example?
Certainly.
This is the most recent one that accompanies the most recent standard operating procedure. The SOP explains that it must be displayed clearly in public areas within the building. Could you put up EPUT 009884 at page 19, please? So this is the poster that would be up on the ward so patients could see it.
Yeah, and the point I'm referring to is the bottom of that. If I read it out, says, have concerns or want to know more, please speak to the ward manager or nurse in charge. And then it says, privacy notice in the use of person identifiable salient video data Further information on your data rights and how the Trust uses your data can be found at the website, and alternatively you can contact the Trust Data Protection Officer. And this poster is also included in the welcome pack.
Okay, let's just take it in stages.
And that's what I was referring to.
Thank you very much. So what we can see here is use of video. When can staff see in your room? A clear image can be seen for up to 15 seconds, only when checking your pulse and breathing rate. A blurred image can be seen for up to 15 seconds, only when a notification has been received. Nowhere does this poster expressly state that the camera will be on and recording all the time. Correct?
Correct.
I think what you're saying is that that information is available if you go through the functions or the website that we see at the bottom of the poster.
Yes.
Do you think that that is really a way to be providing important information to patients in a mental health inpatient unit who may be troubled or vulnerable?
As I said earlier, it's important, and we were clear about this, that information is explained and provided to patients in a variety of ways and not as a one-off event. So that includes both at admission, staff should be having conversations. There's videos available that, one of those is at the QR code on the patient leaflet, which I'm sure you'll take us to later. And through ward community meetings and other places. So, I absolutely recognise that people, full stop, whether they're patients, have different preferences and abilities to engage with different types of information. That applies to everybody and particularly applies in a mental health setting. That's why we'd have multiple mechanisms. I mean, on the specific point, could this have been more prominent? Yeah, I absolutely accept that, and I think that's something that, as a trust, we'll review further. We have a deep dive on Oxyvision planned with our quality committee in November, so it's certainly a matter that I'll be escalating there.
And use of terms like privacy notice in the use of person identifiable salient video data. That's quite obscure, isn't it? I mean, for the layman, I'm finding that quite obscure.
I think privacy notice is very commonly used by organisations, but the salient video data, I agree with you, Chair, that's confusing to most people.
Okay, just let's look at the leaflet because that provides more information.
Yes.
And then, again, this is referred to in the latest standard operating procedure. Could you put up EPUT 010164 and go to page 3, please? And can we see just the bottom there? Can staff use the system to see into your room? The system doesn't show a continuous live feed. Ward staff can only see a clear view of your room when measuring your heart and breathing rate for up to 15 seconds. You can also see a blurred view of your room for up to 15 seconds when they receive a notification. Could you go over the page and expand the text at the top? How is your privacy protected? As well as the 15-second time limit on viewing your room, there are safeguards in place to protect your privacy. There's no sound. They also can't see inside your bathroom. And then we get this. Here are some of the other measures in place. Recorded clear video can only be viewed by authorised staff if there's been a safety incident, and it must be requested within 24 hours. You have the right to be informed if this happens. All clear video is only kept for 24 hours. Then it's automatically deleted. Now, is that the kind of wording that you were referring to earlier?
It's slightly different on the website.
Okay. But again, there's nothing here to expressly tell someone that a camera is on 24/7 and recording.
I suppose this comes to the clarity of language, but recorded clear video and clear video is kept for 24 hours, that would, to me, imply that there is recording. Now, I accept that, you know, these documents can be made clearer on the point that you're making.
Okay, thank you very much. Would you take that down, please?
And the QR code had the IS on it, but that takes you to a 4.5 minute patient-friendly video. I've viewed it, that our quality matron has been using with patients on our wards where they've asked about Oxyvision, or where she's asked them about Oxyvision. Two-way conversation is important there, clearly, to show them that. It is a video that's been produced by OxyHealth, but we found it to be useful in helping patients understand that system.
I viewed it as well, Mr. Trent, and it's the same point there. It doesn't expressly state that the camera is on and recording 24 hours a day. I'm going to come on to a new topic in a moment. I'm just wondering whether now might be an appropriate time for a break, because we've been going for about an hour. Do you want to say something first?
May I say one more
Yes, of course.
point? And I think it goes again to this recording point. For the vast majority of patients, that 24-hour recorded video will never be seen by anybody. You know, for the vast majority, it's as I say, it's in a limited number of cases under specific circumstances. And I think we've probably already discussed that sufficiently, but I wanted to say that because for the vast majority of patients, that will never be viewed by anybody.
No, I do understand that, but isn't the point that it would nevertheless be significant to a patient to know that there was a camera in their room that was recording them at all times?
I accept that.
Thank you. Chair, could we come back at past, so a short 10-minute break?
A long 10-minute break, short 15.
Sorry, a shorter than 15 minutes. Mr. Trent, I'd like to now move on to ask you about the rollout of Oxyvision at EPUT, please. This is what you say at paragraph 10 of your second statement. The Oxyvision system was first implemented at EPUT in 2020, following demonstrations to clinicians at EPUT Lab in 2019. Could you just briefly tell us what EPUT Lab is?
Yes, it's a monthly meeting which is really well attended by senior clinical staff, particularly psychiatrists and psychologists at the Trust, as well as others and nurses. And it's been running for some time as a forum to explore new innovations and new technologies and to see them demonstrated. Some of those things are then effectively fed back as not worth pursuing, and others are fed back by that clinical, in the main group. There's other managers as well that are worth pursuing.
So in this case, did EPUT Lab forward it on for further consideration?
Yes.
And you go on to say an early insights and implementation lessons learned report, including patient and staff feedback, was presented to the Executive Operational Committee in August 2020. In September 2020, a paper was submitted to the Trust Board of Directors recommending the further rollout, purchase and installation of Oxyvision to support quality and safety across a number of the Trust's inpatient mental health wards. The Trust has continued the rollout of Oxyvision across inpatient and specialist inpatient wards in a number of phases since then. This includes the time to care business case presented to board in June 2023, which detailed the further rollout of Oxyvision onto EPUT wards. Are you happy that that's an accurate summary of the rollout?
Yes.
And you provide more detail about it in your first statement.
Yes.
Could we put up, please, EPUT 009030? Thank you. Now, this is a document that you have provided to us, Mr. Trent, and does this show the wards where Oxyvision was deployed, the number of rooms in each ward, and when Oxyvision went live on each ward?
Yes.
This shows, and I've counted them, a total of 43 wards with go-live dates from February 2020 to November 2024. It shows that 4 wards went live in 2020. Now, in fact, were those the 4 pilot wards for testing Oxyvision? We could see them at the top. Ardley,
yeah.
Chelmer, Hadley Unit and Peterborough.
Yes, those are, and they correspond to the same in my first statement, I believe.
What this shows us is that 26 wards went live in 2021, and then it starts to diminish. 6 in 2022, none in 2023, and 7 in 2024. But can we see that there was a particular expansion of Oxyvision in 2021 at EPUT?
Yes, following that business case, and I would just note that there is some slight double counting in there. For example, you have Larkwood, and then you also have Larkwood LTS underneath it. Those are effectively the same ward, but the long-term segregation part within it. So, depending on how you count a ward,
yes,
then that's important to note.
Thank you. That's very helpful. Could you take that down, please? And we learned from a report that you provided us with from April this year that Oxyvision is currently on, at least as at April, 30 inpatient wards, 4 health-based places of safety, 8 seclusion or long-term segregation, and 2 intensive care rooms. That's from the clinical safety case report of the 30th of April 2025. Does that sound about right?
Yes.
Do you regard that as an extensive rollout of the technology at EPUT?
Yes, I'd say that's a fair description.
In what proportion of mental health inpatient units at EPUT is Oxyvision now installed and used?
So there's a further 5 wards where it is planned to be rolled out, that's covered in the business case, And then there's 11 wards where there are currently no plans to roll it out, but that may be reviewed in future.
But ultimately, on current plans, the substantial majority of the relevant units will be using Oxyvision.
I would say some 80% around
80%.
that.
Thank you.
Yeah. But, you know, so some of those other wards, for example, they're different settings. So, as you know, we provide some social care services and things like that. So they're not necessarily applicable in this rollout.
Oh, I see. Well, that's interesting and helpful to note. But across a range of different types of inpatient unit.
Yes.
Thank you. The inquiry's expert health statistician team will be considering some of the research and feedback to which reference is made in your statements, including as they relate to the evidential base for rolling it out. We've seen that there were 4 pilot wards and so on. So I won't ask you questions about that today. After the expert health statistician has conducted the review, a report will be written and issued, and we can follow up on that basis. Could we move on then, please, to the topic of research? And you refer in your first statement to other evaluations of Oxyvision. And again, the expert health statistician will be reviewing this. But one of the studies that you refer to, and this is at paragraph 76 of your first statement, is research that was jointly conducted by EPUT and Anglia Ruskin University, or ARU. And you say this: ARU and EPUT commissioned an independent study of a multi-site evaluation of the use of vision-based patient monitoring systems and body-worn cameras in mental health inpatient wards in England. And you say this at paragraph 78. The interim results show that staff reported positive feedbacks from VBPMS in relation to communication, 68%, therapeutic relationships, 68%, feeling safe, 76%, and quality of sleep, 68%. 62% of patients reported positive impacts in relation to feeling safe, and 61% reported negative impacts in relation to privacy. 65% of patients and 81% of staff said that vision-based monitoring systems are useful. Those are interim results. Do you know if there are final results, or if there are not, when they might be available?
I met with the principal investigator in, I want to say May. I'd have to check my records. And at that time, I asked her whether this would be complete ahead of these hearings. She did not think it would. The work was going to take longer than that. I'd have to follow up with her directly to have a confirmation. But of course, with any independent study, it's the discretion of the principal investigator to determine that, not the trust.
Well, you've referred to it now, I think, a couple of times as an independent study, and you provided some underlying documentation for it. But as we've heard, it was part commissioned by EPUT, wasn't it?
Yes.
And EPUT had actually been involved in the development of Oxyvision observations, which is a significant element of the technology, isn't it?
Yes, although the technology is clearly owned by OxyHealth. We have no financial interest in that. I would say it's common, and I'm not talking about OxyHealth here, I'm talking about health technology companies in general. It's common for providers to work with them to develop new bits of technology. Often, whether it's a patient record or any other system, our staff will be the people who know where the greatest benefits are from new development. So that's a common occurrence in healthcare, in my experience.
Just following on, at this time, by the time this research was being conducted, EPUT had already committed substantial funding to the purchase and ongoing rollout of Oxyvision. So in those circumstances, isn't that the combination of those factors a substantial conflict of interest?
As a trust, we the reason that we were interested in this study was to, have further independent evidence that would inform our use of it going forward. So, the purpose of that was related to the improvement of healthcare. We have no permanent relationship with OxyHealth. We've heard about other providers and other technologies, and the Trust will, as with all technology and practice, will continually review what we're doing. So, I understand the concern, but that certainly wasn't how the Trust saw it at the time, nor how we see it now. That study is about understanding more fully the technology and getting further insights, and we've heard about how important that is.
In circumstances where the plan is to roll out to 80% or so of inpatient units?
It's quite true that in the meantime, since that was commissioned, we have further expanded our rollout, yes. Thank you very much.
What I'd like to do now is to move on to look at consent with you, please. The CQC conducted an inspection of ePut in November 2022 and January 2023. This culminated in its inspection report of the 12th of July 2023. And I'd just like to look at a couple of aspects of that report with you now, please. Could you put up STOX 009062, please, at page 8? So could you expand from acute wards for adults of working age and psychiatric intensive care units, please? Down. And we can see a bullet point in the middle there. The Trust must ensure patients understand the use of the contact-free patient monitoring and management system, that would have been Oxyvision, including why it's used and how information will be stored and accessed. So this is a page that sets out some of the report's findings, and it shows, therefore, I think you'll agree, CQC concern about information being provided to patients about Oxyvision. But what I'd like to do with you is just to follow that through in the report, please. Could we go to page 102? And expand up to best practice in treatment and care. And we can see here a paragraph that starts at the October 2022 CQC inspection at Willow Ward and Gallywood Ward. The Trust were asked to make improvements around the contact-free patient monitoring and management system. This system helped clinicians to plan care and intervene proactively by providing them with location, activity-based alerts, warnings and reports on risk factor. Not all patients had provided consent upon admission or were aware of the systems in their bedrooms. The Trust told us that they assume implied consent for this system to be used, and they required staff to record if a patient declines. On the November 2022 CQC visit, we looked for evidence of patients' consent to contact-free patient monitoring and management system on Willow, Gallywood and Peterborough wards. We were unable to locate consent within patients' records sampled. On Christopher's psychiatric intensive care unit, one patient had refused consent. Staff took a long time to locate the refused consent in the patient's care records. There was no record of ongoing consent being sought. Staff said the Trust were developing a record to be added to the existing patient's care records, specifically for ongoing consent to the contact-free patient monitoring and management system. We sampled ward welcome packs for Kelvedon and Ardley wards and did not see any information around contact-free patient monitoring and management systems. However, wards displayed posters with brief information about technology to monitor patients' vital signs. And so can we see, just arising from that, concerns about consent and the fact that not all patients were aware of the Oxyvision system in their bedroom. And in this report, ongoing concerns about consent in patient records, the absence of information about Oxyvision in welcome packs, and also potentially limited information in posters.
Yes, we can see those things.
A further point raised in the report was that on one ward, managers told the CQC that it was possible while using Oxyvision to see a patient unclothed in their bedroom following a shower. Were you aware of that concern being raised?
So the CQC report and our response to that are overseen by a working group to address the specific concerns, and we've had CQC action plans put in place in relation to each of the CQC reports that we've received.
Thank you. In wards where Oxyvision is used, do you know whether consent for Oxyvision is now recorded in all patients' records?
Yeah, so this is something that, as I said in my second statement, we've accepted as a trust, we're clear as a trust that, we should have done better. We've now put a specific field in the electronic patient records to confirm that consent has been sought. And I mean, obviously at this time, we're on the previous implied consent model, which, I note is one of the models in the Nurse Directors Forum, and actually we heard yesterday was probably the predominant model in use at the time across trusts. So it wasn't without reference to relevant guidance at the time. However, we recognise that really it's not the right way to do this. So, in terms of changes we've made since that address some of these things, in the patient records systems, Mobius and Paris are our two inpatient record systems. There's an admission checklist, so we now have a box there for staff to confirm that they have actively sought consent. So that's a key change. We've obviously changed the standard operating procedure. The welcome packs, and one of those exhibited, include the poster, and we've been giving patients leaflets. And, like I said, last couple of weeks done 4 focused visits with our quality lead and Deputy Director of Quality and Safety on the wards, and patients have told me there's a poster in my room telling me about Oxyvision, I've seen it on the ward, those sorts of things. So we've been taking steps to address these findings of the CQC, and of course, as a trust, we fully accept the findings of each of the CQC reports.
Thank you. I mean, we've looked at the poster. I don't recall anything in that poster about consent, and likewise, although I'll be corrected if I'm wrong, the leaflet doesn't refer to consent either, the most recent leaflet. We could check all of that. We can come back to it if we need to.
It's very clear in the standard operating procedure and in the communications of staff and so on that this is about actively seeking consent. And if those materials are not clear enough, then we need to improve them.
Yes, thank you. Let's just follow this through, and we'll come on to some of the points that you've made in the context of the actual documents.
Yes.
Now, we have been informed about and provided with a letter from NHS England on the use of vision-based monitoring systems in mental health inpatient settings on the 7th, dated the 7th of September 2023. So this is about 2 months after the CQC report. This is a letter from 3 people at NHS England, a professor, a deputy chief nursing officer, and the National Clinical Director for Children's Mental Health. And it's addressed to mental health provider, chief nursing officers, and chief medical officers. In those circumstances, it should have gone to relevant personnel at EPUT. Would you agree?
Yes.
Could you put up STOX 009063? Can you expand the paragraph under our request for your support? So this says, it is our view that vision-based monitoring systems should never be implemented in a blanket way. and that any decisions to use VBMS in patient bedrooms should be made in a person-centred way, with the patient themselves where they have capacity to make a decision, or through a best interest process compliant with the Mental Capacity Act 2005, where they lack capacity to consent to the monitoring system. The use of such systems should be carefully considered on a case-by-case, patient-by-patient basis to ensure that any decision to use such systems has a legitimate aim and is both lawful and fair. Their use must also be proportionate to the aim. We are, therefore, asking all services to please review, clinically and ethically, current VBMS practice within your organisation to ensure your use of these technologies aligns with the principles of least restrictive, compassionate, therapeutic and personalised care. Would you agree that this is urging that consideration is given to the use of systems like Oxyvision with patients on a case-by-case basis, rather than their use, as it says here, in a blanket way?
I agree with that interpretation of the letter.
And the letter was asking for a review to be conducted into current practice. Can I ask you this? Were you aware of this letter yourself?
I was not directly aware of that letter. It was not addressed to me, as you've said.
Yes.
But I'd need to consult with our medical director, and our chief nurse has since changed.
Thank you. But again, would you agree in 2023 concerns were being flagged about the operation of VBMS, vision-based monitoring systems, and consent being authoritatively flagged?
Yes, I mean, I'd also say that, and I think this is one of the things which can always be a challenge with new technologies. And, you know, the government has been clear in their 10-year plan for health. They want to see a shift from analogue to digital. So there's an expectation of healthcare providers adopting technologies to assist them in what they're doing from the government more broadly. But that at this time, there was not extensive guidance available. NHS England's guidance comes later. The guidance that was available at the time was the provider-led produced nurse directors guidance, which, you know, as we discussed earlier, has the implied consent model in it as one of the two options. I know that the Oxyvision Project Board that meets monthly has continually reviewed the practice of how Oxyvision is used. But on this specific question of how was this letter dealt with, I would have to come back to you.
Thank you. But you've raised an interesting point, a separate point, about where there is a new technology, how that technology should be reviewed, who should be responsible for it, and so on. Is that the point that you're making?
Yeah, and I think this is a really important point more generally for the health service. We do need to adopt new technologies, and very many of these are in the best interests of patients. Some are more controversial than others, and there's an important role here for regulators in supporting provider organisations in this. NHS England's guidance, when published this year, and we've heard in Porter's
we'll come on to that in just one moment.
Yeah.
But just sticking with your point about how a provider such as EPUT is meant to decide for itself how to deploy new technology, what are the ethical issues that arise from it? Is that a point that you're seeking to flag here?
Yeah, I mean, of course, the board of an NHS trust is responsible for that trust, and I would not suggest otherwise, and the decision-making there. But it can be greatly assisted by regulators, and I include both the CQC and NHS England, and other, respected public authorities in providing guidance on these things. But inevitably, new technologies is probably not proportionate to produce guidance on every single one of them immediately. So there does tend to be a lag in those regulators producing guidance.
But are you suggesting, just so that we're absolutely clear, that it would have been helpful, for example, with technology such as Oxyvision, for there to have been a more authoritative set of principles or guidance from a body such as NHS England or the CQC at an earlier stage?
Yes, it certainly would have been helpful.
And do you see those two organisations as the obvious people to be providing that kind of guidance, or are there others that you can think of?
I mean, obviously, NICE, the National Institute for Health and Care Excellence, considers new technologies and appraises those from an effectiveness and an economic perspective. So I think, their analysis is generally, we take their analysis as the principles to which we then apply in trusts our standards of care. So, NICE is clearly a relevant authority here. NHS England, obviously we have regard to their guidance and direction on a regular basis, and they have a position, obviously, to oversee trust, but, they have historically sought to promote best practice and other activities. So, we find their guidance helpful.
Do you think the situation is that too much is left to individual providers, certainly in the early days of technology?
I mean, I think this is such a difficult thing to say one way or another. If you look at the many great innovations that our health services produced over many years, they've probably tended to come from innovative clinicians on the front line, not from a national body, if you were to look at those. And allowing and facilitating that innovation is crucial for the benefit of all. And I think, what this discussion and evidence and others have contributed to, importantly, is about getting that right with different technologies to get that balance right so that there is space for innovation and improvement and adoption of new ways of doing things, but that we manage the risks better. And I think, that's, as I've said in my second statement, something that needs to, should have been done better in the past.
And that is the experience of ePut with Oxyvision. That provides the basis for what you're telling us now in terms of what would have been helpful.
Yes, around having guidance a bit sooner on that, yes, that is our experience.
Can we come on then to the NHS England principles for using digital technologies in mental health inpatient treatment? So these are dated the 7th of February this year and updated on the 25th of the same month. You referred to them in your second statement, explaining, and this is paragraph 13, that NHS England issued guidance on the use of digital technologies in mental health inpatient treatment, including 8 principles for digital technologies, such as Oxyvision, to help clinicians consider whether use of a digital technology is the most appropriate, effective, and least restrictive method of caring for or treating a patient in inpatient mental health settings. You then refer in brief to each of the 8 principles, including principle 2, the requirement that the use of digital technologies such as Oxyvision must be based on consent where a person has capacity. We looked at the principle in the document yesterday, and it said this: any decision to use digital technologies and to collect and store patient data from the use of such technologies must be based on consent from the patient or a person lawfully acting on their behalf, or be taken following a best interest decision-making process. And it adds, where a patient has the capacity to consent to the use of digital technology in connection with their care and treatment, consent should always be sought from the patient, and the use of the digital technology should be regularly reviewed with them, and if appropriate, with their families and carers. And we also saw yesterday that the principle referred to the need for personalised decision-making, and that digital technology must never be used in a blanket way. And it then set out also a particular process where patients are unable to consent. Does that all accord with your understanding of Principle 2?
Yes.
Thank you. Would you agree that it should have been clear to ePut by now, after this principle and the earlier NHS England letter that we looked at, that Oxyvision should not be used in a blanket way? That is, in all rooms, with the default being that it's turned on?
Yes, and I mean, I just want to address that piece about the default being that it's turned on. So in response to this guidance, we changed our standard operating procedure, as you know, and our assessment was that our new standard operating procedure was in line with this guidance. On the specific point about blanket restrictions, I can appreciate there'll be a concern that we say in our updated guidance that the system would be switched on typically at the beginning, and then the consent should be obtained in up to 6 hours.
Can I come on? Because I would like to ask you specifically about that when we come to the
Fine,
SOP.
yeah, of course.
So rest assured, I'll ask you about that specifically.
Okay.
I think there may have been another part of the NHS England principles that you wanted to refer to. Is that correct?
Yeah, so I wanted to note that, on this point that we discussed earlier about surveillance, NHS England does not say in this guidance, and it would have been a clear opportunity to do so, that they consider vision-based monitoring systems to be surveillance systems. They do refer to a literature review on surveillance, and they do warn against using systems as surveillance. But, in having regard to NHS England guidance, had NHS England said, we consider vision-based monitoring systems to be surveillance and to be inappropriate, then of course as a trust we would have responded differently to that than we did with the guidance that they published. I'm saying that because this debate about whether this technology is surveillance or not is not just restricted to this trust. It's of national importance given the number of trusts. And I wanted to note that in terms of NHS England's guidance.
Thank you. Can we just come on to the last but one standard operating procedure, version 11. Now that was issued on the 28th of February this year. So shortly after the NHS England principles had been published. And it was approved, as I've just said, on the 28th of February. You refer to it in your first statement, this is paragraph 42 to 43, explaining that the target audience for the SOP are inpatient staff. You say the SOP sets out how Oxyvision works, what it's used for, and how staff are trained in its use. The SOP also sets out that every patient must be informed about the use of Oxyvision, and that staff will have a discussion with patients, carers, and families at the point of admission. Is that all correct?
Yes.
And has EPUT actually had an SOP, standard operating procedure, in place since the 26th of March 2020?
Yes, right from the beginning, yeah.
And so there have been various iterations of it between then and the most recent one?
Yes.
You also explain, and you've touched on this a few moments ago, that version 11 of the SOP operates on a model of implicit consent. Let's just deal with that quickly. Is it right that the SOP explains that where Oxyvision is installed, the system is continually switched on and monitored, therefore all patients are opted in upon admission as part of the standard ward practice? And you summarise the position in your first statement in this way. It is standard practice for EPUT to use Oxyvision unless a request is made by a patient not to use it, and this request will go to the multidisciplinary team, the MDT, for review. That's paragraph 52. So would you agree that this appears to be a blanket approach, this penultimate SOP, whereby a patient is opted in by default to the system on the basis of implicit consent to its use?
I would note what I said at paragraph 41 about objections can be raised at any time during the admission episode, and the points that you quoted about there's a clear expectation in version 11 and previous versions that this is discussed with patients and carers at the point of admission. So, on the point about blanket, the policy is clear here that there must be a meaningful conversation. It has started from a premise that the system is on, and the meaningful conversation would then take place, and only if that concluded it needs to be switched off was it switched off. But there is clearly in the policy the requirement for the meaningful conversation, which would be unique to that patient and therefore not blanket in its approach. However, we have also accepted in reviewing the NHS England guidance that that starting point was the wrong starting point, and that we should flip it round, and it should be opt-in, as it were.
But essentially, version 11 of the SOP operates an opt-in implicit consent process.
Version 11.
The penultimate one.
Yeah, version 11, you have to opt out
Yes.
of the process, but you should be informed and have a meaningful conversation with staff according to the process.
Do you accept that version 11 does not follow the NHS England principles in relation to consent?
Yes, I accept that.
So this SOP, coming after the publication of the NHS England principles, effectively ignores them.
Well, I've addressed this in paragraph 13 of my a third statement. There's a timing lag here. The update that went through on in version 11 was part of the normal 6-month review, and I think it even says 6-month review with rewording, no activity detection and minor changes. So that was a routine update. At that point, the Trust hadn't completed its review of the new guidance, and I absolutely accept that version 11 wasn't compliant with that, and we didn't move to a compliant position from our assessment until 7th of May.
Would you agree it was a pretty pointless update?
I mean, I'm not sure I'd necessarily use those words. I'm sure the intention of the rewording and other changes was to make it clearer, so I wouldn't describe that as pointless. But was it a significant update? No, it was a routine update.
Is there an issue with EPUT issuing SOPs with minor changes which serve no particular purpose?
When you're making improvements to policies and procedures, and we've spoken a lot about clarity of language and transparency earlier, even some small changes that make something clearer can actually be important. So, I think the important thing here is that the SOP is being regularly reviewed. And when you go through the 12 versions, yes, there are some, like 11, which are incremental in their changes. There are others that are more fundamental in their changes over that period.
And so you've touched on the period between version 11, which comes out shortly after the NHS England principles, and then bringing us up to version 12, the most recent version. And effectively, do we have a process where there is review of the principles of a focus group that had been conducted, and I think also some external legal advice had been obtained, and were all of those three sources used to decide ultimately to agree the SOP in its form that we see in version 12?
Yes, that's correct.
But we've seen the history, haven't we? We've seen CQC reports in 2022 and 2023 raising issues of consent. We've seen the letter from NHS England in September 2023, which said that VBMS should never be implemented in a blanket way. Do you think this is a reasonable point to make, that EPUT should have reviewed and amended its approach to conflict significantly earlier than in the version 12 SOP?
I think it's arguable to think about whether the consent could have been changed earlier. It's possible it could have been changed earlier. Did we have national guidance that really supported us in that change earlier? No, we didn't, not in that way. That was published by NHS England in February. And in my second statement, we've accepted that when we look back at that, we probably should have changed it earlier.
Thank you. So let's come on to version 12.
Yes.
And you talk about this in your second statement, from paragraph 2022. This is what you say in 2022. The principal changes to the SOP in the latest version, version 12, relate to consent. This is paragraph 22.
Sorry, which of my statements?
In your second statement.
In my second statement. Thank you for bearing with me.
Do you have it there?
Yes, thank you.
The principal changes to the SOP in the latest version, version 12, relate to consent. In line with the NHS England guidance, that's a reference to the NHS England principles we've just been talking about.
Yes.
The latest SOP takes a human rights approach with a focus on individual informed consent at the point of admission and throughout treatment and/or assessment on mental health wards, with consent to be recorded explicitly in the patient record. This is a significant change from the previous approach of informed, implicit or implied consent, where patients were provided with information about the system and consent was implied unless an objection was made. The specified time limits for responding to the withdrawal of consent by a patient have been changed from a maximum of 72 hours to a maximum of 6 hours, and the updated SOP is clear that the system should be switched off as quickly as practicable and safe. Now, are you still happy with that description there of the essential changes in SOP version 12?
Yes, we've spoken earlier about the additional emphasis on making sure that the system is only used for its proper purpose. I noted that earlier in the evidence I've given today. I think that's an important one as well as what's here.
Thank you very much. Can we look at the relevant part of the SOP? Could you put up EPUT 009884 at page 9? Can you... That's perfect, thank you. So do we see here paragraph 1.5.2, Oxyvision informed consent process? And can we see, as part of the admission process, all patients must be provided with clear, accessible information about the use of Oxyvision and Oxyvision observations? And then looking at the second paragraph, patients are encouraged to ask questions, express any concerns, and given the opportunity to fully understand how and why the system is used. The patient will be informed that the Oxyvision system is currently in an on state, and they will be required to give informed consent for this to remain on, or the Oxyvision system will be switched off within 6 hours. Now, that's what you've just been describing in your statement. Just dropping down, consent for the use of the Oxyvision system must be obtained and clearly documented in the clinical case notes. And I think that's something you actually referred to a little while back as well. Could you expand the bottom half of the page, please? From if there are concerns. Thank you. And we could see in this paragraph text that says, if there's a reason to believe that the person lacks mental capacity to make the decision, they should proceed to make a best interest decision, they being a reference to the nurse in charge along with the responsible clinician or duty doctor. And we can see also in that same paragraph, where there is reason to believe a patient lacks mental capacity, a multidisciplinary team, MDT, meeting should then be arranged to specifically review this decision as soon as is reasonably possible. So could we deal first, please, with the situation where a patient lacks capacity? Does the SOP and what we've just looked at mean this, that if it's believed that a patient lacks capacity, the decision about whether to keep the system on is made in the first instance by the nurse in charge and another clinician, and then reviewed in a MDT?
Yes, and I think the reasoning here is to be as timely as possible. So it refers to the nurse in charge along with the responsible clinician or duty doctor, and that's recognising that admissions happen at all times of day and night. So if somebody were to be admitted late in the evening, it might not be feasible for an MDT to happen until the next day, And so what this procedure is being clear about is that those responsible clinicians who are on duty at that time must consider mental capacity for the individual. And it's not saying that they should be predisposed to one answer or another for that individual. They should, I'm not a clinician, as I've said, but they should follow their established practice in undertaking that best interest assessment for that individual.
Let's unpick that. Let me ask a few things about that. So the system may be kept on until the MDT, which may take place sometime after the 6-hour period. Is that correct?
No, if the nurse in charge and the responsible doctor said this should be switched off now, it would be switched off now.
I understand, but in the other scenario, the nurse in charge may decide that the system should remain on, in which case it will remain on until the MDT convenes. Is that correct?
Yes, because essentially they would have then done a best interest assessment, concluded that it should stay on, and then that would have been further reviewed at the MDT. But they would have been acting in accordance with their professional duties and assessments.
No, I understand all of that. It's just the timeliness element I wanted to ask you about, because we've got this 6-hour time period now. But if the nurse in charge or the equivalent clinician decides that the system should remain on, the ultimate decision will have to wait until the MDT, and that could be some time after the 6-hour period has elapsed.
No, I disagree with that, because I think the phrase ultimate decision is not quite right. The nurse in charge and the duty doctor are undertaking a capacity assessment with reference to the Mental Capacity Act. So they are doing that at that time. And then additionally, there's going to be a further review and assessment of that later. So, that is a clinical decision at that point in time. There may be a further review, and I think one of the things that the SOP talks about is that capacity is not a constant. So it may be that somebody's capacity changes over time. And this is a well-established point in mental health care, that you have to regularly return to questions of capacity.
Well, I think the SOP talks about returning to every week or so, or every 6 days. Is that right?
Yeah, but the responsible clinician and the nurse in charge and the team should be responding to this as in whatever frequency was appropriate as well. So they have to have the ownership of the care.
Understood. So you're saying that, in fact, the nurse in charge decision is the decision, and that will happen within the 6-hour period?
Yes, and we're clear here. It's a nurse in charge along with the responsible clinician or duty doctor.
Thank you. Yes, thank you for the correction. Do you know whether, in fact, in most cases of patients lacking capacity, the system is actually kept on?
I don't know the answer to that question.
Thank you. Can we move to the situation for patients with capacity? And we need to just read a little bit more of what's on the screen, the second paragraph. If the patient consent is not given on admission, or is withdrawn during the admission process, or following the MDT clinical decision, the Oxyvision system can be individually isolated by the nurse in charge using the monitor to select camera off for that patient's bedroom. So here we see the procedure using Oxyvision to actually isolate the camera in a particular room. A decision to turn the camera off should only occur if the nurse in charge or doctor deems the action clinically safe prior to a MDT decision meeting. So this is referring to the MDT decision meeting. If the nurse in charge or doctor deems this to not be clinically safe, then the Oxyvision system will remain on, and the rationale to be explained to the patient and clearly documented in the patient record. Can we just deal with what that's saying? So this relates to patients with capacity. Have I got that right, first of all?
Yes.
Do you understand it to mean this, that if such a patient does not give consent, the system may be turned off?
No. What this is trying to say is that if the patient to not give consent, then the system should be turned off. But the turning off of the system, there's important considerations around that in terms of maintaining good knowledge and working across the ward. So, if for example, a nurse were to switch the system off but not tell the rest of the team, that would be a cause of concern, because they might think, oh, it's on when it's not. So, this paragraph, and I can accept it, it probably needs some redrafting to make it clearer. This paragraph is trying to say that, there may be reasons in the clinical judgment of the nurse in charge that needs to be delayed. I mean, perhaps there's an incident and they're responding to it. It might mean that they can't switch the camera off immediately. Perhaps there's other issues. I couldn't be exhaustive in what those scenarios might be. But the nurse in charge must make sure they've used their clinical judgment risk assessment of what's happening on the ward to turn it off safely with other colleagues properly informed.
Right. Let's deal with that in stages. First of all, you're saying this paragraph lacks clarity.
I think, to the question that you've said, I think its clarity can be improved.
Okay. Can we just follow through? What it appears to say is that a patient with capacity can refuse consent, but that the nurse in charge or equivalent clinician might decide effectively to ignore that because that person doesn't feel it's safe to turn off the system. And the words that are used, a decision to turn the camera off should only occur if the nurse in charge or doctor deems the action clinically safe prior to an MDT. And so, as this reads, the suggestion seems to be that even a patient with capacity refuses consent, there is a scenario where the camera may remain on.
I mean, if the nurse there was an immediate safety concern or something going on, then the nurse has to make that judgment. The reason that it says this needs to be clearly documented in the patient record is because this is allowing for a very limited set of possible circumstances. The clear intention of the SOP is that if a patient withdraws consent, you switch the system off, you do that as quickly as practically possible. And this practically possible point, admission processes are quite long, complex processes. Our steps for that, there's 43 steps to go through on admission. And wards are complex environments with lots of different things happening at any given time. And so, our nurses in charge are constantly judging a number of different factors to keep patients safe and engaged and supported on the wards. And so, here we're trying to acknowledge that and recognise there may be some limited circumstances, but if that's the case, it's effectively a deviation from the core intent of the SOP, and it must be documented. And that will allow for subsequent audit and review and improvement.
Can we just deal with that? So you've talked about the 43 steps that need to be gone through. So this is a busy ward with a clinician who's got a lot to get through. How on earth are they going to properly explain consent in the context of all the other matters they have to deal with, and relying on a standard operating procedure which is drafted in a way that lacks clarity and understanding?
I mean, I don't accept that the whole procedure lacks clarity and understanding.
Well, in respect to this particular issue?
I accept this paragraph could be improved. In terms of that admission process, the team have to go through a number of steps and do each of those conscientiously. A discussion about consent on Oxyvision is not a discussion that necessarily is going to take an hour. It could be quite a short discussion. It depends on the individual patient, and I can't say it would take this long or that long. Our clinicians, they're experienced in supporting people in moments of crisis, supporting people with different states of capacity, and they make complex judgments every day and work with patients with complex and different needs in different circumstances. So, the policy's there, it's really clear, and that conversation needs to be had at admission, and we would expect staff to do that.
Thank you. I said I'd come to the point that you were raising about opt-out or opt-in. But would you accept this from me, that as we've seen, the system is initially switched on as a default for all patients and across all wards, and this revised consent process still actually remains an opt-out rather than an opt-in model?
No, I wouldn't accept that, and I'll explain it a bit more. When considering standard operating procedures, they're operating procedures. They're about how things happen in practice, and the practical elements of this are really important. The time it takes somebody to walk from one place to another, to have a conversation, to carry out a task matters. So, we know in healthcare safety literature more broadly that communication and time for communication is incredibly important for safety. So the point of saying up to 6 hours, and it is up to, and the policy is clear, it should be as quickly as practically possible, is to allow the time that in whatever the practical circumstances are of the admission, working through all of those steps, what's going on in the ward, that the nurse in charge and the team would be able to have that conversation as soon as practically possible.
Has the Trust considered having Oxyvision turned off as default and turned on only if a patient consents?
Yes. So, this was something that the quality matron for Oxyvision was heavily involved with and discussed with staff on the wards. The reason for having it switched on at the start is, again, a practical one about safety and understanding on the wards. Often patients will move between rooms as part of an admission. There might be a patient moves from A to B and things like that. And the view of staff was that there was a risk that if they had to try and switch rooms off at the point of discharge, that a patient moves from a room, that might mean that there wasn't a common understanding of the room states. So by having it on at the beginning, the staff across the ward would be clearer about the current position and how to maintain the safety and oversight of the ward. So it was I'm not sure I've explained that as clearly as I might have. It came from on-the-ground discussions between the quality matron and ward staff who were concerned that the room state should be clear for all staff and patients at admission.
But wouldn't turning it off as default at the start and then opting in effectively be more consistent with a properly informed consent model?
So I think the point here is we're trying to change this as quickly as practically possible, and as I said, that practicality is important, and that there are other considerations around the overall safety and communication around the ward that mean that the view of staff and the quality matron was that the ward safety and overall safety of patients would be better supported by having it on at the point of admission. I do think these are issues which, as I referred to earlier, will be considered further in the Quality Committee deep dive in November. The Trust's Quality Committee has already planned a focus session on Oxyvision, where it will be considering some of the things I've set out in my statements, where we're audits and so on, to look at how this is working in practice following the latest change to the operating procedure.
And that's something you can report back to us once that has been produced?
I would be very happy to, and that will give us also an opportunity to consider the important evidence that's been heard in this inquiry over the last 2 days.
Thank you.
Given that one of the principles of the NHS guidance is about therapeutic and personalised care, would you not accept that it would be a more personalised approach to have it off and to consider the needs of individual patients and whether it should be switched on?
The policy's clear about that.
Therapeutic and personalised care.
Yes. I mean, the point of having the conversations at the beginning and having the informed, explicit consent is to be in line with that guidance. The practical points about switching it off, it's clear it should be switched off as quickly as possible. So, the 6 hours, I would expect it will be switched off more quickly than 6 hours in most cases. And it may be switched off as soon as that conversation is had. But the procedure has to allow for a variety of situations. So it's more permissive than that. Chair, I think, if there weren't the other considerations raised by ward staff about communication and consistency and understanding of the environment, then we probably would have had it switched off at the beginning in this SOP. And I think certainly it's something that the Quality Committee will be interested in considering further. But it was the practical considerations in order to support a therapeutic and personalised approach.
Thank you.
Could you take that down, please? You say, just moving on to a different topic now, you say in your third statement, where you cover impact of change from the version 11 standard operating procedure to the one we've just been looking at. This is paragraph 45. You say that EPUT is not yet in a position to provide comprehensive data or detailed analysis regarding the full impact of the changes implemented between version 11 and version 12, because more time is needed to embed the process across all wards. Now, is that what's being looked at the moment? Is that what the report will be covering?
Yes, exactly. I mean, the Quality Committee will be looking at exactly those matters, and I've highlighted in my statements several of them. The commission of an internal audit focused on consent in Oxyvision, and that internal audit's method includes going to look at a sample of patients to understand whether this policy was followed in practice, and I think goes to your question, Chair, about how quickly and how adequately was that addressed for individual patients. So that internal audit will help us understand it better. We've also, and I attached some examples, been using a Tendable. Tendable is our kind of an audit system we have. Tendable audits, which is where staff self-assess compliance with the standard operating procedure. The two examples that were attached showed compliance, but there are others that don't, and that's an opportunity for staff to review and revisit and make changes. And then the other thing I referred to in my statement is patient focus group meeting. In fact, rather than holding a focus group, the patient experience team determined to go out onto the wards, and so we had feedback from 46 patients to a number of questions about their personal experience of Oxyvision, which is being compiled into a report which will be considered. Early findings from that are clear that we do not have full compliance with this at the moment.
Sorry, just pause there.
And patients are still reporting their
So you don't concerns. At the moment, the information is that the process set out in SOP version 12 isn't being fully complied with.
That's correct.
Thank you. I want just to finally ask you about cost. Is it correct that
Sorry, can I
yes,
ask
of course,
one
Chair.
question
Yes.
about consent?
Yes.
As I understand it, there is a weekly discussion once somebody has opted out as to whether or not that wish still stands. Is that right?
Whether they've opted in or out, it would be regularly reviewed. It's not specific to them having opted out.
Right, okay.
And, there's also regular community meetings on the wards where Oxyvision is expected to be an agenda item. I've heard from patients that has been their experience. And the individual nursing team should be regularly revisiting these questions. And they should be revisiting that whether the patient said they wanted it or whether they didn't. It's not specific to their choice.
And so this is a free discussion once a week with the whom? With the MDT and the patient about...
As part of the discussions about their care, they should be revisiting these questions, yes.
Including inviting them to opt out should they wish to do so, or rather drawing to their attention that they could opt out. Is that right?
Yes.
All right.
But that's the theory. But at the moment, the information you have is that it's not necessarily being implemented properly.
That's right. For some patients, they are reporting, and I've heard this in my recent visits, and this is shown in the early indications I've had from the patient experience team. Some patients are getting that experience and saying, I did have a conversation on admission, I have been told about this, it is in my community meetings, and I have heard about it from staff regularly. Other patients are saying, I don't know enough about this system, I don't feel I've been properly consulted on it or engaged on it, or had my consent taken or not. So we are, from our patients, still hearing a variety of experiences, and I anticipate that the internal audit will also show areas where we need further improvements to be fully compliant with the SOP. I mean, I would note generally for healthcare providers that compliance with standard operating procedures requires continued work and focus. And when you look at reported statistics, when people are talking about standards, they're often not 100% standards that they're measuring against. When they're looking at mandatory training compliance, for example, is a good example. Trusts won't have a 100% mandatory training compliance in general terms because they recognise there'll be reasons and constant improvement activities.
Thank you. The inquiry will be liaising with ePUT through its legal team to ensure that we get all relevant information.
Certainly.
So Chair, I was just going to deal with one more topic briefly, and that was cost. Is it correct that the total cost to date of the contract with OxyHealth runs into millions of pounds?
Yes.
Do you know what the actual figure is?
I know what the figure is for how much was spent in 24-25.
And what's that?
That was approximately £1.2 million. To put that in context, we spent our business case for time to care is to spend £14 million on increased staffing on the wards. And as a trust, we turn over in the same financial year, £580 million of income related to patient activities. So that 1.2 is about 0.2%. And it compares to around £420 million spent on staffing as a whole. So I say those because I'm not diminishing the sum. It's an important sum, but it has to be seen in the context of the organisation as a whole.
No, I understand the point about millions of pounds possibly being a small proportion of the overall budget, but it's still millions of pounds. Do you think, after what we've been discussing today, that Oxyvision actually represents a good use of public funds and value for money?
We went through business case processes to decide as a board to invest in Oxyvision. And if I take the time to care business case as an example, that follows the government guidelines on 5-case business cases. So there was a clear and robust assessment in that of the strategic case, the financial case, the economic case, the management case, and the commercial case. So on the basis of that, the Trust Board did agree that it was value for money and an appropriate investment. That case sets out the safety priorities, and I do want to, I'm not very good at turning the pages. I do want to note the point, I think, in my first statement, that our evidence on our Datex incident reporting system is that over the a multi-year period that I've cited there, over 1,400 incidents, staff have ticked the Datex reporting note to say Oxyvision played a role in alerting us to this incident. In the patient focus group that we held in March, a patient there said, Oxyvision saved my life. I mean, that was their experience. I know others have had other experiences and some terrible and tragic experiences. Staff have often told me when I've been visiting wards and asking them about Oxyvision, this has helped us in saving lives. So, you know, I think we talked about innovation and technology earlier. It's really important that these debates are had, and you know, we welcome the inquiry's focus on these matters. I think it will be of service to us and to the NHS mental health providers more broadly. But we must look at all sides of that, because you know, our experience has been that this has supported improvements as well as having risks and issues that we've talked about.
Thank you very much. Chair, those are all the questions that I have for Mr. Trent at the moment. Could we break, subject to any questions you have at the moment, so that I can liaise to see if there are any further questions? I'm going to aim to come back at 5 o'clock. It's possible, Chair, that I'll ask for a little bit more time than that, but we will make that request through other channels.
Thank you.
Thank you, Chair. Mr. Trent, a few more questions. First of all, I'd like to go back to the I Want Great Care feedback we looked at. I'm going to ask that EPUT 009020 is put up on the screen again, please. Now, if you see there's the top right-hand corner, there are 4 boxes there, and we looked at the entries in the second row. Can I just draw your attention to the text that we see below that? So this is in relation to the 1st of February 2024, Chelmer Ward at Princess Alexandra Hospital. So the same ward at the same hospital, but 2 or 3 months later on. And we could see the text there that says, yes, really safe with staff and with Oxy Health and staff personal cameras. And can a mirror be put in the laundry room, please? So I've just been asked to draw your attention to those. Are those, well, the first of the 2 comments, is that the kind of comment that you've heard as well?
Yes, I mean, you know, this I Want Great Care allows for positive and negative feedback. It's something we implemented to support us in better listening to patients and their families, and it's all publicly available. And we do receive positive comments as well. And you know, when I've spoken to patients on the wards, and you see this in Professor Nolan review as well, you know, some patients do acknowledge the safety benefits of it, and they, you know, I spoke to patients recently who said, yeah, actually for me, I would like that on. That's helpful to my care.
And that picks up on what you were saying at the end of the last session we had about the positive aspects of the system.
Yeah, but I mean, that is not a universal view, and you know, obviously, and we've heard evidence of the contrary. But you know, that is also what some people have said. Yeah.
That's very helpful. Would you take that down, please? You've been clear in your evidence that you expect all therapeutic observations to be undertaken by staff in person, with OxyObs there as a tool really to enter data. Beyond revised training, and you spoke about that with the majority of it being online, what practical steps has EPUT taken in order to ensure and monitor staff adherence to this policy requirement?
So you've heard before about the Time to Care programme, and you know, we keep mentioning it because it's one of the big transformational programmes that we're undertaking at EPUT, and you know, that £14 million every year investment is a significant one. As part of that programme, we have been going through an implementation checklist for each and every ward, and we've got a broader Time to Care standard operating procedure, which really engages staff on you know, these overall principles to focus on more patient-centred, personalised care, to be more trauma-informed, to use that multidisciplinary team better. So, you know, that steering board has been overseeing those changes. That's important in relation to that. I've already referred to the regular ward visits undertaken by the quality lead for Oxyvision, but there's a number of other senior clinical staff that regularly visit wards. Directors of nursing and the chief nurse go out to wards usually on Fridays, but every week to talk to staff and engage with them and talk about the fundamentals of care. So, you know, there's a number of different things going on to support improved adherence to that, and you know, it is about the core focus of improving care.
Thank you. To what extent has EPUT considered Comparative Trust's patient information literature on the use in Oxyvision in formulating and revising its own patient literature on this technology? The suggestion is that other trusts provide much more information and much more accessible information in their patient-facing documentation. So is that something that EPUT has done, to have a look at what other trusts are doing?
Yes, absolutely. So EPUT's been actively involved in the Nurse Directors Forum, for some years, including in the Standard Operating Procedure Working Group. It's also been involved in the communities of practice. Our quality matron for Oxyvision and the service manager, the kind of systems manager, both of them engaged with that and share practice and materials. So I know they've discussed different practices around the documents. I couldn't tell you here immediately what documents have been shared between trusts, but that is something we could address in the further statement that I promised.
That's fine, thank you very much. I mean, this inquiry may conduct further investigations which might include having reference to the equivalent documentation produced by one or more other providers to compare for purposes of clarity and other reasons. Do you accept that the evidence you've provided as to the circumstances in which it would be clinically unsafe to deactivate a camera, this is in relation to version 12 of the SOP, where a patient with capacity has refused consent, don't amount to a clinical rationale as to why the Oxyvision camera should remain on? It's more of a staffing resources issue.
I mean, I say in my statements, I'm not clinically qualified. And so, you know, in answering that question earlier, I've sought to, you know, describe circumstances that may be applicable. By no means were those exhaustive. And, you know, you would want to take clinical evidence or, you know, evidence from a clinician. And, you know, we can follow up with colleagues to give some specific examples of that. So, you know, I would suggest that those were not exhaustive. I was not making a clinical assessment, and that we can provide some further evidence from our clinical leads if that would assist the inquiry.
Thank you. Ms. Cousins couldn't answer yesterday, but said an EPUT witness could. How much EPUT is spent on Oxyvision in the last few years, since it was deployed there? You were here yesterday to hear her evidence, so you might have been expected to have prepared to answer the question. Can you help us, even with ballpark figures, what the total spend on Oxyvision at EPUT has been?
I don't want to give you an incorrect sum, and while it might seem as though that would be a simple exercise, actually I commissioned that piece of work a week or so ago to find out the latest spend before hearing Ms. Cousins' evidence, and it did take the finance team a couple of days to work through invoices and other things. So I wasn't able to immediately have that information. I know that the initial business case presented at the outset talked about a 1.8 million investment over 4 years, but the information the inquiry seeks can be provided, and we will provide that in terms of the total spend since inception.
That's helpful, but of course that 1.8 was foreseen at a time when the rollout hadn't extended to the 40 plus.
I mean, that's precisely
Yes.
why I gave you the 1.2 million of 24-25, because it's recent and reliable.
Thank you very much. Ms. Cousins told us yesterday that Oxyvision was used in police cells. Was that something you were aware of?
I note that, you know, Hap Porter's latest statement referred to, you know, a point in my statement about Oxyvision being designed for mental health. That was not intended to express that it had only ever been designed for mental health. It was intended to say that at the time we engaged with Oxyvision, we understood it to be a system that had been designed, you know, had further been designed or, you know, for use in that setting. And we were not the first to work with that. We knew about Oxford Health and we knew about Coventry and Warwickshire at the time.
Just dealing with the question, were you aware from an early stage that Oxyvision had been used in police cells?
I mean, I wasn't at the trust at that early stage, so I don't know whether people were aware or not.
Were you aware from your early stages at the trust?
Not immediately, no. I wasn't aware of that.
Do you know whether EPUT was ever given data relating to its use or effectiveness in police cells or prison cells?
I am not aware that we've ever received that. I can undertake further searches, but I don't believe we have.
In fact, I've just said prison cells. I can't recollect now, frankly, whether there was a suggestion it was used there. So let's just stick with police cells for now. So you're not aware if any concerns may have arisen from its use in that kind of environment?
Not that I'm aware of that were specific to that were shared with the Trust, no.
Was EPUT one of the first trusts to trial Oxyvision?
As I said, the papers from the time clearly refer to Oxford Health and Coventry and Warwickshire having already been using Oxy Health. I think, when you look at the, circa half of mental health trusts using Oxyvision now, we were probably one of the earlier ones to adopt it, but I don't have an analysis of when other trusts took it on, but I know we were aware of at least 2 that had already done that before us.
Do you know if EPUT has been used by Oxyvision to recommend its product to other trusts?
We wouldn't make a recommendation of a product.
The question is whether Oxyvision has used the EPUT experience to recommend its product to other trusts.
I don't know whether that's the case or not. I would think that Oxy Health would be best to respond to that.
Fine. Sorry, I said Oxyvision, Oxy Health. Issues relating to continual monitoring now, please. When did you personally first know that Oxyvision does, in effect, record constantly through a 24-hour period?
When I reviewed the DPIA, that was a key piece of evidence that I reviewed at that time. As you can see from the documentation, the first DPIAs for this were data protection impact assessments, were approved before I was at the Trust. But when one came to me for a review, I reviewed all of that information.
Would you agree that the 24/7 filming and recording of a patient in their bedroom constitutes a very significant invasion of privacy?
We've discussed extensively, these issues earlier. There clearly is an invasion of privacy, and that has to be put against the robustness of the consent process, because and we accept this elsewhere in healthcare that people can consent to different forms of treatment to support their care.
But can I just cut to the quick with this question, please?
Of course.
Even with the what you've described to us in terms of securing the data and only using it in confined circumstances, even given that, would you accept that filming a patient in their room 24 hours a day constitutes a very significant invasion of privacy?
I will, the Trust would not make that overall assessment. The position that we've set out is that we recognise there's balance here between privacy and safety in the provision of care, and that needs to be struck and supported by a robust consent process.
How many staff, to your knowledge, have been disciplined at EPUT for the misuse of the vital signs system?
I don't know the answer to that question immediately. We would have to review our HR and disciplinary files in order to answer that. I would also caveat that to undertake that research, you'd have to be mindful that in reviewing that, it may not be as precise as the vital signs system was inappropriately used, because as I've spoken about earlier, the concern would be a staff member has not followed proper conduct. So I think that would be quite an extensive exercise. It could be undertaken. Right,
so that might be something the inquiry should follow up on with you and your legal representatives at a later stage.
Certainly, we'd be happy to engage with you about that.
Thank you very much. You talk in one of your statements about quality walkarounds focused on Oxyvision being undertaken by the Deputy Director of Quality and Safety and the Quality Matron on a monthly basis. How frequently does the DOQ the Deputy Director of Quality, and the trust-wide quality matron address high instances of observations, will the Director of Quality and the quality matron disclose work to the inquiry about the wards of concern? Did you understand that question?
I think I get the central the focus of the question. We'd be happy to provide the inquiry with further evidence about how our senior clinical staff provide supervision and oversight of the wards, and the relationship between that and the project board where those usage reports are reviewed, which we discussed earlier.
Thank you. Do you agree with Laura Cousins that because your patient population is so varied, having Oxyvision on by default isn't appropriate?
I don't agree with the premise of that statement or question. I've explained earlier that in our latest standard operating procedure, we've got an explicit consent at the outset, and we seek to implement that as quickly as practically possible.
So your answer goes back to the explanation that you've given to us previously?
Yes, and further, the point about having a varied population, which we do in Essex, of people with a wide range of needs, care needs and support, is again coming back to that individualised conversation about consent, which we've talked about.
Thank you. Can we go back to the usage reports, and we looked at elements, if you remember. You were asked about one of the graphs with specific attention being drawn to a graph that suggested there were a significantly high number of vital sign attempts. Do you remember that? Is it correct that a vital sign attempt would be reflected within these figures, these very high figures that we were seeing, if a member of staff had selected the tile of a bedroom as if to carry out a vital signs check, but for whatever reason did not then complete the workflow?
That's a technical question for how the data is calculated from the system. So we'd need to check that because it's quite precise, that question.
It's a very precise question, I accept.
Is it on the first click or the second click, effectively? Usually in clinical systems, you'll be able to, somewhere in the code, audit the two different clicks. I don't know which one OxyHealth have used. I think they would probably be best to answer that question.
So, or we may go back to ePut in terms of the way it's configured for the,
either.
the trust. Because there are questions here about at what stage one would access the clear video feed. And so this is another area where the inquiry may follow up with ePut and or OxyHealth, just to ensure we understand the procedure and therefore can understand the figures that we've been looking at. So you're willing to cooperate with that?
And certainly we'd be happy to show you in practice on the wards with an empty room or a volunteer or something like that, if it would assist the inquiry, because my experience is that it's in the visits and the conversations that you really get to understand how this system's being used. Thank
you very much. You said that to your knowledge, OxyHealth do not have access to clear video data. An extract from an ePut Data Protection Impact Assessment from 2023 states that under certain circumstances, clear video data may be clipped, marked for retention on the local secure server so that it's not recorded over, by OxyHealth remotely, and in some cases securely transferred to OxyHealth's facilities. Now, that might suggest that OxyHealth do or did in fact have access to clear video data in some circumstances. Is that something that you were aware of? Because that falls within your time at ePut.
So they shouldn't have access to the clear video data, and I think the exhibit to Laura Cousins' statement which is their latest DPIA and data management principles, has in there the risk that Oxyvision staff could access it and talks about the controls that prevent that. So, I maintain what I said earlier, which is my understanding and our data protection officer's understanding is that they cannot access that Clearview data. One thing that's important, we've spoken a lot about 24 hours. 24 hours is the maximum. So, when clipping data, and certainly, after clipping it, there's that further stage of the data protection officer determining that it's appropriate use. The final stage where someone views that, they'd only be given access to the bit that was proportionate for that particular purpose. So if someone was requesting to say, look, there's been a serious incident and we need to do that patient safety investigation, that might relate to a defined period of an hour or some other time, that they wouldn't be given the whole 24 hours. They'd only be given that defined period that was proportionate to the purpose and use that was.
Yes, I think you gave an example about a time frame, or at least
yes.
We certainly covered that with Laura Cousins. But that's again an issue that we may follow up with you and possibly Oxy Health in terms more precise detail of exactly where data is held and in what circumstances. Again, you're willing to cooperate with that.
So certainly, of course.
Thank you very much. You were asked about the EPUT clinical safety case report, and under the heading Oxyvision Observations, it's observed that Oxyvision can be used to conduct non-intrusive observations at level 1 and 2, but not for levels 3 and 4. Does that actually reflect EPUT's policy? For example, does that actually reflect EPUT's policy?
Yeah, I think that's consistent with the policy. When you're getting into, level 3 and 4, you're talking about people being very close to the patient for most of the time.
No, so I think the question isn't directed on whether it can also be used for levels 3 and 4, but that seems to suggest that Oxyvision observations can be used for remote observations for levels 1 and 2, which would be inconsistent with your evidence earlier today.
No, I don't think it does indicate that. I think when it's saying non-invasive, non-intrusive. Apologies. Then I give the example of somebody who's asleep. The staff member needs to still have line of sight, be professionally assured that that person is safe and well, and can then take their breathing and heart rate without having to physically touch them while they're sleeping, for example. That would be what that's referring to in terms of being non-intrusive. Non-intrusive should not be taken there to mean remotely. They're different. But
would that, or might that be another example of unclear language being used in EPUT documents?
I don't think that one is, no. Others I have accepted, but yes. That one I don't think it is.
You say, well, let me ask you this. Is it possible or even likely that on EPUT wards today there are patients who have not been asked at all to give consent to the use of Oxyvision in their bedrooms, if even for an initial period of 6 hours?
That, as I've said, that is clearly contrary to the standard operating procedure, and we expect staff to follow that, and there's posters in the wards and in the bedrooms and so on. I've already referred to some early findings from the patient feedback that says that some patients say that hasn't been their experience. So I can't stand here and say we've got full compliance, because I've already said to you I don't believe we have full compliance.
No, I understand, but does that mean that it's possible that on EPUT wards today there are people where Oxyvision is being used who haven't been asked to consent?
Well, that is what some of the patients have said.
Thank you. And does it follow from that it's possible that there are people on wards today who haven't been told by staff that the equipment in their bedrooms include a camera that's recording constantly?
So, I think, as I've said earlier, there are, it's possible that people haven't followed the procedures and policies fully. As an organisation, we've sought to put in place controls and oversight to improve compliance with that, and we continue to focus and improve on that.
So I think I understand your answers. I've got a series of points I'm going to put to you, and maybe we can deal with them globally,
Certainly.
because I suspect your answer will be the same. But I want to put to you a number of potential scenarios on EPUT wards today in relation to the issue of consent and other matters. So also, do you think it's possible, let me ask all of these scenarios and then answer in one go. Do you think it's possible that people on the wards haven't been told that the system is continuously attempting in the background to take their vital signs, have not been informed that continuous clear video footage is being held for 24 hours, have not been informed that blurred video footage is being held by a private company, OxyHealth, for a period of time, have indicated that they do not consent but are still subject to the use of the system, are being watched for contiguous periods of 15 seconds by members of staff accessing cameras remotely on tablets, or are experiencing distress and or paranoia because of the use of cameras in their rooms. Now, I know that's a number of different scenarios, but taking them globally, do you accept that it's possible that on the wards today we might see instances of each of those examples?
I accept that those things are possible. I would also say that they're likely to be possible on every mental health trust, because when we're talking about compliance here, it's very difficult to be able to guarantee 100% compliance on these matters in general terms, and that point about compliance is something that healthcare organisations in general focus on continually and repeatedly, because there are often issues with compliance. So I think I can't obviously say that these things aren't possible. They are possible, but that is not exclusive to this organisation, and needs to be seen in a wider frame of systems of reasonable and appropriate controls and oversight.
Thank you very much. Mr. Trent, those are the questions I have for you. Chair, do you have any questions for Mr. Trent?
No, I have no further questions. Thank you very much indeed for your evidence today. Thank you.
Mr. Trent, thank you. Chair, that's it for today. We reconvene tomorrow at 10 o'clock. Thank you very much.